So I guess in the name of talking real estate, I'm in a rent-to-buy position in the esophageal community, hopefully going towards buying. So I'm going to spend the next half hour or so talking about Barrett's esophagus. I'll touch on the impact of Barrett's, the challenges in diagnosis, management guidelines that I think are soon to change, at least with the ACG, hopefully coming out with new guidelines in 2015, and then we'll talk about treatment options. So let's start off with a case. This is Mr. B, who's a 56-year-old gentleman who comes into your office basically to establish care, but also has heartburn and regurgitation. He tells you that his symptoms have been ongoing for about 8 years. He intermittently takes PPIs, H2 blockers, sometimes, a bottle of Tums here and there, a couple of weeks or so. His past medical history is significant for coronary disease. He has hypertension. He also has hyperlipidemia, family history of GERD and coronary disease. And he has a social history of a 25-pack year smoking history. And BMI is 36, otherwise on exam looks relatively healthy. So in your assessment of him, you start to think, well, what should I do with this gentleman? Should I just stabilize him on a PPI, stabilize him on an H2 blocker, depending on how he responded to his H2 blockers, schedule him for an EGD, or just talk with him about lifestyle changes and have him follow up in a year? We'll talk a little bit about what we know in regards to Barrett's esophagus. So we know that chronic GERD is a risk factor for Barrett's. We also know that Barrett's is a known precursor to esophageal adenocarcinoma. The goal of screening and surveillance in our patients with Barrett's is to detect and eradicate dysplasia. And while dysplasia is our best predictor for cancer, it's an imperfect predictor. As you all must have come across, dysplasia can be seen in non-neoplastic tissue that's just healing from injury. So it's not 100% sensitive for cancer. And unfortunately, despite all of our efforts in screening and surveying people, and esophageal adenocarcinoma still has an incidence that's arisen over the last 3 decades. In fact, it's outpaced colorectal, lung, breast, prostate, melanoma in the last 3 decades or so. In 1973, they quoted about 3.6 per million, and now in 2006, it's about 25.6 per million patients that are diagnosed with esophageal adenocarcinoma. So given this impact, all 3 societies endorse screening and surveillance, but the question really is, who should we screen, how should we screen, and when should we screen? And again, this is an ongoing debate because to date, we still don't have clear answers on that. So I show this study by Doug Rex that was done in 2003, and this was a population of 961 patients that presented for outpatient colonoscopy, average risk screening, and they were recruited to undergo voluntary endoscopy. And 65 of his 961 patients actually had Barrett's esophagus. That's roughly 8% or so, so a little bit, or sorry, 6%. It's a little bit higher than our literature now, which quotes prevalence in the US of about anywhere from 1.7 to about 5%. But I show this slide because it's interesting. We have a Barrett's population in the patients who are presenting with heartburn, but you also have a significant number of those patients who don't have any symptoms. So the big question is, are we missing these patients who may not have heartburn? As you can see from here also, majority of the patients had short segment Barrett's, and about 50% the literature quotes of patients who have short segment Barrett's will not have symptoms. Long segment Barrett's is associated with long-term reflux symptoms, so that's a little bit easier for us to identify, but it's really these asymptomatic patients that we're concerned about. So in the challenges in changing kind of the trend for Barrett's, we really need to pay closer attention to the significance of asymptomatic Barrett's esophagus. And again, no mass screening guidelines for these patients. And despite this, the patients who are presenting with cancer are diagnosed at a late stage, and interestingly, less than 5% of those patients diagnosed with esophageal adenocarcinoma are under surveillance for Barrett's. So we're seeing these patients, they haven't even been brought to our attention previous to that. So it's not that we're not catching them at the right intervals, it's that we might be missing the boat altogether. And lastly, still a poor 5-year survival with these patients, less than 20% at 5 years. So talking about screening, our patient that we saw was a little bit of a slam dunk as far as the risk factors, but just to review them, high-risk population would be the Caucasian males greater than 50 who have long-standing reflux. Other risk factors for both esophageal adenocarcinoma and Barrett's are obesity, smoking. They carry a family history of Barrett's or EAC. But still, the ACG in 2008 didn't really specify who should be screened, and I quote this from their guidelines: screening in selected populations at higher risk remains to be established and therefore should be individualized. The AG is a little bit more firm about patients who are presenting with GERD and also with multiple risk factors as I had mentioned above. These are the ones we should screen. And the ASG from 2012 writes, screening EGD for Barrett's esophagus should be considered in selected patients with chronic long-standing reflux. In 2013, Rubenstein's group published in the Red Journal a tool using GERD, age, obesity, and tobacco to predict the presence of Barrett's. And what their recruitment strategy was very similar. 822 patients who came in for screening colonoscopies. They make a note that their population was a little bit more towards male, overweight, and potentially with symptoms. But of those 822 patients, about 8% were found to have Barrett's. And what they found was their model based on all of these things: GERD, age, tobacco, obesity, more accurately classified these patients with Barrett's than just reflux alone. So I guess, the take home from all of this is, in looking at your patients, yes, most of the ones that we'll jump on will be the ones that have long-term GERD, but I think it's really fair to kind of consider potentially screening if the patients are meeting other risk factors that we know for esophageal adenocarcinoma. And hopefully the guidelines that will be coming out maybe will give us a little bit more information on the right population. So in our gentleman, he's Caucasian, he's 56, he's got long-standing GERD, he's a smoker, he's obese, pretty justified in going ahead and performing an EGD on him. So in just talking about the pathophysiology of Barrett's here, we'll start off with, what actually happens. Well, we know that chronic reflux and reflux of both acid and bile causes damage to the esophageal squamous mucosa. And what I always tell my patients is it's the healing process that's really the concern. The esophagus is not used to that acid exposure, and so the healing process occurs through a metaplastic process, and unfortunately this is what in fact increases the risk for esophageal adenocarcinoma, where columnar cells replace the squamous cells. Now, why some people develop this and why others can regenerate squamous mucosa is really an unknown variable for us, and really points to the ongoing need for evaluation with biomarkers, and hopefully that's definitely in the works and down the pipeline. But when we look at the esophagus and we study these patients, as far as defining Barrett's from an endoscopic standpoint, it's displacement of the squamocolumnar junction proximal to the GE junction. This is based from the Chicago workshop in 2004. But as we know, gold standard is really obtaining these biopsies, and it's the transformation of this squamous mucosa to specialized intestinal metaplasia, which we define as the presence of goblet cells, which you'll see there in stained in blue. Now, in diagnosing Barrett's, I think we all kind of take it for granted. We look at an endoscopy, we kind of fly through the GE junction, and one of the things I always take away is, I was at one of these talks, and someone had said, the GE junction is really the area which is the most common area in the upper GI tract where cancers form, but we fly through it all the time and people don't really pay enough attention. So I think it really warrants a careful endoscopic look. But the pitfalls in the diagnosis are really identifying endoscopic landmarks, location of the biopsies relative to these landmarks, and this is incredibly important for the pathologists, to let them know exactly where these biopsies are coming from. Is it coming from the cardia, or is it coming from the esophagus? Because the biopsy, your treatment strategy will change depending on that. And then, of course, from a histologic standpoint, the presence of pseudogoblet cells. And as you can see here, these pseudogoblet cells here are just dilated, mucin-filled columnar cells that can look like goblet cells, but don't stain blue. So in talking about the endoscopic landmarks, just something that, when I get these referrals for dysplastic Barrett's, I'm always looking for a couple of different things. I'm always looking for someone to mention the top of the gastric folds or the anatomic landmark, which is the GE junction. And I don't see it very often, and it can be a little bit difficult for us to either categorize these patients correctly as long segment or short segment, or exactly where their Barrett's is. So identification of the gastroesophageal junction, which I had mentioned is where the top of the gastric folds are. And then normally the squamocolumnar junction should be located in that area, but of course in Barrett's we know that this is displaced. So just to kind of depict that, you see the top of the gastric folds on the image on the right of the screen, and then on the other side you see the pinch of the distal esophagus, which we will call the GE junction at that point. So in assessing these patients endoscopically, I usually use a cap whenever I have anybody who's coming in for either Barrett surveillance or screening, and I think there's a high suspicion for Barrett's. Detailed white light exam, if that's all you have, carries a great sensitivity and specificity, over 90%, just requires careful observation of that area. Narrowband imaging has really good inter-observer agreement as well as a high specificity and sensitivity. And this is basically imaging technology that I think we all have on most of our scopes. And it highlights the mucosal pattern and capillary network. It's very helpful in patients such as this one where it might be a little bit hard to see the Barrett's mucosa versus the normal squamous cells. But under MBI, it's really apparent. So incredibly helpful. Of course, it's most helpful before you biopsy because after that, your really visualization changes dramatically once you have blood in the field. But sorry, I didn't mention, the other two modalities, of course, are confocal endomicroscopy, which Greg touched upon for biliary imaging, and then also chromoendoscopy, which uses contrast agents. Confocal endomicroscopy is a technology that we have at MUSC and that I use on my patients. Sometimes with dysplasia, it's hard because there's not a lot of big studies regarding inter-observer agreement. And its utility, you know, I use it more kind of as an education point for myself in being able to depict dysplasia. Very hard to see low-grade dysplasia versus high-grade dysplasia, but if you have high-grade dysplasia in comparison to just regular metaplastic Barrett's, it's quite apparent on confocal endomicroscopy. And what you see is really similar to what Greg had mentioned. You start to lose, you start to get architectural distortion and then dilation of the vessels. In invasive cancer, of course, there's no pattern, there's no real there's no real organization at all when you are using this. But as he had mentioned, you know, when you're looking at the image, it's in vivo images, so the cells are moving, and it's a really dynamic picture. So it is at the same time that it's kind of breathtaking because you're seeing these live cells move. It can be hard to localize, and I find using the cap really helps to kind of focus the probe as well. So in just looking at some of the images, for non-dysplastic Barrett's, you can see under white light, you know, sometimes it's a little bit hard to tell the extent of the metaplasia. Under NBI, it's a little bit more clear, and with endomicroscopy, you really see these columnar cells, you see the goblet cells, and you see fairly normal vasculature. With dysplastic pictures here, the NBI imaging is showing really dark areas with increased vascular pattern. Under endomicroscopy, you see distortion. You see a lot of dark cells here and dilated vessels, so that starts to be a little bit concerning for dysplasia. Again, high grade versus low grade is very hard to tell. And then this is confirmed on histopathology with high grade dysplasia shown there. So in translating the information as far as what you're going to put on your reports, GE junction is imperative, recognizing the squamocolumnar junction in respect to the GE junction, and of course being able to describe the extent of the columnar mucosa. The verbiage that is most helpful, or the language that's most helpful with us who deal with Barrett's, is of course the Prague classification. We're using C and M criteria. So C representing the circumferential extent of the Barrett's. The M criteria, or the M portion, is the maximal extent of the metaplasia. And then, of course, all of this is in relation to the true position of the GE junction, which is the top of the gastric fold. So just to be able to depict that, you have here the top of gastric folds, and approximately 2 centimeters from that is circumferential Barrett's, and then 5 centimeters from that is the top of the metaplasia. So this would be C2, M5. So as far as techniques for biopsying, esophagus is constantly moving. You know, it's probably one of the more challenging areas to biopsy, and so the method that's recommended and that I often use and teach the fellows is a turn and suction biopsy. So putting your probe out and bringing and sucking so that the mucosa comes to you so that you can be as accurate as possible with your biopsies. Biopsying mucosal irregularities, we'll touch on that in just a little bit, but within Barrett's tissue, any sort of mucosal irregularities, whether it's ulcerations, nodularities, really have to be biopsied separately and should be, mainly because of the chance that they harbor something a little bit more advanced, advanced neoplasia or advanced dysplasia. 4-quadrant biopsies to be done every 2 centimeters. These, of course, should be separated. And then in high-grade dysplasia, if this is a patient that you're surveying, 4-quadrant biopsies every 1 centimeter, and it's found in studies to decrease sampling error by about 50%, which is why we do it. So in our case, we have Mr. B, who had circumferential Barrett's, but also had an area here that looked a little bit more nodular, had some concerning aspects here under NBI with increased vascularity. So whenever I see this, I start to wonder, is that an area of concern? And I'll biopsy that often separately just to make sure that if in fact it's concerning to me on endoscopy, hopefully I can get specific biopsy results from that area. So in his case, he did in fact have long segment Barrett's, defined as Barrett's greater than, equal to or greater than 3 centimeters. So he had C3, M5 Barrett's and had a high-grade nodule at 35 centimeters with the topogastric folds being at 40 centimeters. So you've just kind of thrown a bomb on him. He had no idea about Barrett's. He came in for heartburn and reflux, and all of a sudden you're giving him this diagnosis. So his questions are, will I get cancer? And do I need treatment? So we'll talk a little bit about the progression of Barrett's here. So this is kind of just a picture of normal lining and then the eventual change to invasive carcinoma. This, of course, goes along the metaplasia, dysplasia, neoplasia sequence. And in this multi-step process, what you see are the cells starting to undergo these changes. Then you get cell disorganization, atypia, and then eventually invasion of the carcinoma. As far as progression to high-grade dysplasia, in studies that were done in the early 2000s where patients were followed for high-grade dysplasia, shortest follow-up time was 5 years. You see a significant portion of these patients actually developed cancer. And while there is some population, or there may be some bias here, you know, we'll talk a little bit about the possibility that these patients who were labeled as high-grade may have in fact had intramucosal carcinomas that just blossomed into invasive carcinomas. A study by Konda's group in 2008 showed the risk of cancer. They analyzed 23 articles, and basically about 440 patients were taken for esophagectomy for high-grade dysplasia. And among that population, about 40% of those actually had an intramucosal carcinoma. Of that, in trying to delineate whether it was intramucosal versus submucosal, only 14 studies differentiated that. But what they noted was that about 13% of these had invasive esophageal adenocarcinoma, and you worry about lymph node metastasis in these cases. Of course, these patients did have full esophagectomies, so it takes away that concern that you didn't necessarily remove all of the cancer. But it really points to the fact that when you have high-grade dysplasia, you could be harboring something more significant. And right now, we quote about a 6% incidence per year, and all of the societies really are advocating for eradication therapy. I think in your patients that you would recommend potentially surveying, those would be patients who are either old or older in the sense that they may not be able to. You can't. But and that their comorbidities may outweigh the benefits of potentially doing endoscopic eradication therapy. So I gave us a little bit of a slam dunk as far as what we would do for our patient. But let's say he had low-grade dysplasia. Now this area is a little bit more controversial, mainly because the natural history of low-grade dysplasia is still unknown. This study by Bergman's group, Curvers, in 2010, basically did a prospective population-based study from 2000 to 2006, and they registered about 1,200 patients with Barrett's esophagus. 147 of these patients were labeled as low-grade, but actually on re-review, only 22% of these patients had low-grade dysplasia, so about 15% actually had the true diagnosis. 110% were downgraded to non-dysplastic Barrett's. In the patients who had low-grade dysplasia, 19 of those 22 patients showed up for follow-up endoscopy. 42% of them progressed to high-grade dysplasia within 2 years, or intramucosal carcinoma, and 26% remained at low grade. So, you know, the take-home point from their standpoint was that low-grade is overdiagnosed, but when it is confirmed, then these patients, the risk of cancer is actually underestimated. More recent study, actually, and this is in regards to treatment, was from Fo's group and published in JAMA this year. 136 patients were randomized to either RFA versus surveillance. Eradication of dysplasia occurred in 98% in the ablation group, but 28% of the patients who didn't have anything done to them actually regressed. A chance of progression to cancer was quite high in the surveillance group here at 8.8%. So it makes you think, you know, this is one of the caveats to the study, is were some of these patients actually high grade or mislabeled, and then the chance of progression to high grade or esophageal carcinoma was 26% in the surveyed group. So just a couple of caveats. You look at the study and you think, well, you definitely should treat them, and I do offer treatment for low-grade dysplasia. Some of us do at MUSC, and I think it's a real discussion you need to have with the patient. I think the main thing here is you need several pathologists who can confirm low-grade dysplasia, and then I think you really need to have a discussion with this patient as far as what their risk or anxiety is about the development of cancer. We usually quote about a 1.7% per year risk of developing cancer. But you know, this study points to the fact that while yes, you can definitely help ablate these patients are going to need continuous surveillance. And just in this study, about 271 RFA sessions were required for these patients to obtain a 98% success rate. And there were 19% of those patients had adverse events, whether it was strictures, perforation. So those are very real risks that we really need to talk to our patients about. And this is, you know, with anything, I think with high grade, you have much more clout in saying, hey, we worry about cancer. But in low grade dysplasia, we do have to have that conversation with them. Having said that, I think it's really important, you know, in your patients to be able to gauge from them what their sentiments are about treatment. And then this is just to drive home the point with the importance of having expert pathologists kind of look at the specimens. This is Skasel's group in 2000, which is a retrospective review, but 25 patients with low-grade dysplasia were reviewed by 3 independent pathologists. And if 2 to 3 pathologists agreed on that diagnosis, up to 40% of those patients progressed to high grade within 2 years. So again, area of controversy, but I think more than anything, to really be able to confirm that diagnosis is going to be essential to having that discussion. As far as non-dysplastic Barrett's, the risk is incredibly low. In 2000, that risk was quoted at about 1%. We know now from more recent studies, this is closer to 0.3% or so per year. The role of ablative therapy in non-dysplastic Barrett's is a big question. And you can imagine if we're having this much of a debate with low grade, the question about non-dysplastic is really up for debate. We don't do it routinely at MUSC. It's not something we offer. I think there's a lot of evidence to say that these patients are better served being watched. But the role of ablative therapy is unknown because we don't know what the chance or what the problem is with buried metaplastic glands. So buried Barrett's, as it's called, this is a hot topic also for surveillance after ablative therapy. The durability of the neosquamous epithelium is an unknown to us. The longer we have these patients post-ablation, the better off the better we'll be able to answer this question, but it's still a big question. And then repeating the EGD for treatment, it's costly, it's complicated. You commit them to several endoscopies in a short period of time, and that's a real risk for them as well. And we're not sure that we're going to change that incidence of cancer. So just to kind of point to the guidelines, the ACG, like I said, this is under review now, but 2015, I think the new guidelines will be coming out as it's being revised presently. AGA from 2011 and the ASG from 2012. I'll just point to the main differences. So repeating surveillance for non-dysplastic Barrett's, the ACG recommends it within a year, and mainly that's just to reduce sampling error for dysplasia. The AGA doesn't really comment on it, and the ASGE really says once you have Barrett's, you can stick to that diagnosis and keep them surveyed in 3 to 5 years. The ACG has 3 years as an appropriate interval. I think that's going to move more towards 5 years in their 2015 guidelines. I think most of the societies will kind of move towards that. I think the biggest thing that we really need to tackle is mainly who we're screening. Low-grade surveillance interval, so if somebody opts not to have treatment, surveying them 6 to 12 months, anywhere in that point. High-grade surveillance, I think 3 months, you have to be really careful with these patients with the numbers I quoted. But for the most part, those are the patients you want to offer endoscopic eradication therapy to. In our gentleman's case, so what now? We offer to treat him, and in his case with that nodularity, endoscopic mucosal resection is probably the best thing for that area, mainly for eradication purposes as well as for staging purposes. So if there's a 40% chance that it's harboring something deeper, then this is the best way to actually appropriately stage it as far as if it's going to be deeper than the submucosa. And most of the EMRs I do in the esophagus are the cap-assisted EMRs. So the thought is, you know, with the cap-assisted, you're going to get mucosa and submucosa. The suction capacity should not be strong enough to grab the muscularis. So you can get a really nice end block resection of these nodularities. You know, if they're a centimeter or so, I use these caps go over a 1T endoscope or therapeutic endoscope. The diameter is about 11.2 millimeters, so you can get a 1 centimeter nodularity. But if you have a larger nodularity, you know, kind of doing it in piecemeal fashion is totally appropriate as well. And then, of course, with all of our Barrett's, the goal is to eradicate all the Barrett's completely. And the reason for that is there's about a 20% chance of metasynchronous lesions in these patients. And studies have shown that that has popped up in about 2 years or so. So we treat all of the Barrett's, and this patient underwent radiofrequency ablation as well. I think Cryotherapy is something else that we offer at MUSC, which is a freeze therapy. It has great sensitivity and specificity. The way we decide on which one, the way I decide on which one I'll do is really just getting the lay of the land for the patient. Just to touch on surveillance, which is a big question, and hopefully we'll get some answers. So this is all based on primary histology for the patient, and patients who have high-grade dysplasia, usually you can claim eradication after you get 2 negative endoscopies. Thereafter, these patients should be getting endoscopies every 3 months for the first year, every 6 months for the following year, annually thereafter, and how long we continue that is really up in the air. So sorry for speeding through that, but thank you.